Good evening. We're going to wait a little time to get people in, since a lot of guests are logging on at the moment. Okay, logging on is slowing down a little bit. Let's start with the webinar. So we're in time. Good evening, ladies and gentlemen. It's my pleasure to welcome you to today's webinar from the Neurooncology section of the EANS. We put together very nice talks with very nice speakers on planning and executing tumor surgeries on a beginner's level. After the 3 talks we're going to have today, we will have a discussion focusing a little bit on how we were trained and how we used to train our younger surgical residents and fellows. So I think we're going to dive right into the first talk that will come from Helsinki. Päivi will talk about how she does it planning a tumor surgery. Thank you for being here.
Okay. Oh, hi everyone. Good afternoon. So I'm Päivi Korknapal from Helsinki, Finland, and I will talk about planning tumor surgery in a beginner's level. I made multiple steps that guide you through this, and starting with preoperative evaluation. Of course, we first need to know the history of the patient and the current status of the patient. The question is whether we should operate or can we just observe. What kind of surgery do we need? Is it open surgery? Is it biopsy? And we need to have a hint what is the most likely diagnosis, because we need to know whether we have enough labs or other examinations. And you should not forget that are there any trials that the patient could be eligible to. And of course, last but not least, really important question, what is the patient's own opinion about the treatment we have planned? Timing of surgery, second step, it's really rare that we have to do emergency surgery, though that we are in a hurry. Maybe the most important patients are pediatric patients. I have 2 patients here. The first one is an 11-year-old girl with esotropia for 1 week, no headache, no nausea, nothing. And the head MRI was taken just before Christmas holidays last year. We can see hydrocephalus, papilledema, tumor on the left side with a quite huge cyst, and enhancing part of the tumor going through the insular cortex. And what is the timing of surgery here? The patient is doing quite good. The image is looking not so good. And we had to postpone the operation for 4 days until we could get the experienced neuroanesthesiologist from holiday, and everything went fine. This was a pilocytic astrocytoma. And then a younger patient, 4-year-old, balance problems, headache, nausea, hydrocephalus, and post-fossa tumor. For this patient, we did ETV on admission, and on the 2nd day after that, we operated the tumor. So pediatric cases, timing, you should think about like be more aggressive in timing than in adult cases. And imaging, do we have enough images? Do we need something extra, MRI? Do we need tractography? Does the tumor locate in eloquent areas? Do we need functional studies? We use functional MRI only for speech lateralization, but I know some places use it for mapping. That is also really relevant question. And we use transcranial magnetic stimulation for motor area mappings. You should bear in mind that these might postpone the operation 2 or 3 weeks to get these and the results. And fourth step, surgical preparation. We start steroids and proton pump inhibitors, usually when there is edema, anticonvulsants when needed, but not maybe I would say not as a preventive treatment. And then we have to discuss whether what we need in the operation theater. Do we need navigation? Do we have navigators enough? Do we need fluorescence? Do we need something special like intraoperative monitoring, await surgery? This is the setup for await surgery in Helsinki. We can have it, I would say, within 2 weeks from the initial idea. So at least it takes that much time. Do we need intraoperative EEG or MRI or ultrasound? And these should be taken account even, I would say, 2 or 3 weeks before the operation. And what about the positioning? Maybe one of the most crucial things, like during positioning, comfortable and practical working position should be agreed by the neurosurgeon and also for the scrub nurse, so we can maximize the mobility of the operating neurosurgeon. The head should be elevated approximately 20 centimeters above the level of the heart, and to increase the view and access, we can use the help of gravity. Venous outflow should not be compromised by heavy tilting of the head, and padding is important. The pressure areas should be protected with patch and cushions. And I have some images from different most common positions. These are from Helsinki Microneurosurgery book, a bit old book, but anyway, supine position. This is maybe the most common one. Then we have prone, lateral, and sitting position with pneumatic compression tights. And this is for adult patients. We use this. I think these are from the Second World War time. It's really old. And for pediatric cases, just these bandages. So what about the incision? The incision should be adequate enough for good bone and brain exposure, but keeping in mind the blood supply to the scalp. On the upper corner, I have a patient with frontotemporal low-grade glioma. I made a quite big pterional approach, and then we have another patient with glioblastoma, small area, and straight incision. When doing craniotomy, also always the bone thickness and attachment of the dura should be taken into account. And in pediatric patients with thin cranium, if the thickness of the bone is under 2 millimeters, I would use diamond drill and not Triffon. And we use good neuroanesthesia, not only in the cases for elevated ICP. We use quite often mannitol, sodium, hypoventilation, and head elevation. So next to the tumor removal and all the previous steps, this is the 8th step. All the previous steps lead to tumor removal so that it would be really safe, fast, and efficient, and regional anatomy, vessels, functional anatomy, this all should be taken account already much before this day. And what is the principle in not only surgery, but in medicine, do no harm. We do maximal resection without long-standing neurological deficits. And we should have enough samples for pathology to have the diagnosis. And precise hemostasis, of course. So postoperative care, ICU recovery for 6 hours at least. This is depending a lot the ways of the house. In our adult hospital, we use ICU for 6 hours, and in pediatric cases, it's just recovery, exception for post-fossa tumors or deep located tumors. We need neurological examination frequently, and if we have new neurological symptoms, whether anticipated or whether surprise, and significant post-op hematoma risk, it's not high, but you should keep that in mind. And postoperative imaging when needed at proper time, hopefully within 72 hours after operation. So 9 steps. Every step is really important. I'm a glioma surgeon, and I selected 3 of the main steps that I think are the most important, in my opinion, and this is my opinion only, but I would highlight these 3. So preoperative evaluation, really important. Maybe the most important is the surgical preparation. You know what you're going to do. You have all the equipment you need planned, and the positioning. You can make things really easy or really hard for yourself while operating. And these all happen before the incision. So the main thing is not the tumor resection. It's something that happens beforehand. Okay, that's it. Thanks.
Thank you very much. I forgot in my opening remarks to tell you all the drill, but I think you know it. So if you have questions, please use the Q&A, and we'll try to accommodate as much questions as possible. I can't see a burning question right now, so I would like to continue with the second talk and then discuss a little bit in the end of the webinar. Our second speaker comes from Mainz in Germany, and she will talk about how she does a brain met in one of her real life cases. Noreen, please, the stage is yours.
Thank you very much. So do you see it correctly now?
Yes.
Great. Thank you very much again, and good afternoon also from my side. I would like to show how we do brain metastasis here in Mainz. And let's start with some few words to brain metastasis. Well, it's a very common intracranial tumor, and therefore also important, of course, for a learning curve for residents to learn how to remove intracranial tumors. It has a high incidence, and about 10 to 40% of all cancer patients have a brain metastasis during their life. So it has an increasing incidence due to a better treatment of different cancer types, better imaging, and also because of aging population. We have some cancer types which are most often associated with brain metastasis. It's one of the main tumors are the lung cancer, breast, and melanoma, but also renal and colorectal cancer often metastasize to the brain. Important is our knowledge from the last decades regarding the molecular markers, which are really important and which are leading to targeted therapies and prolonged survival. So what are our treatment goals, and what should motivate us to remove a brain metastasis? So the first thing should be to prevent and to delay a neurological deterioration. Of course, prolonged survival with an acceptable quality of life, and that should be the indication for a local therapy. And then we decide whether we do stereotactic radiosurgery or a combination of both. I would like to present a case. It is a 58 years old woman who had presented a few weeks ago with a gait disturbances and occurrence of focal seizures. And she was diagnosed a non-small cell lung cancer in April 2018. And important is to know that she had this KRAS mutation and had a targeted therapy with a stable disease. And until now, the first image we had from June 2019 showed a small parasitical metastasis, which was asymptomatic. So she underwent a stereotactic brain radiosurgery, and it was stable until a couple of weeks ago. And now we saw the patient with the clinical deterioration and had another MRI image, which showed that the lesion has grown, and we had a large perifocal edema. So the indication for a resection of this lesion was made, independent from the knowledge whether it's metastasis growth or is it a radionecrosis resulting from the initial radiosurgery. So what we have to consider is what also some facts we have heard in the first presentation. What is about the surrounding tissue, where is the lesion located, and what I have to consider. So here we have the precentral gyrus, and the parts of the tumor are growing into it or pressurizing on it. Then we have to consider the approach. So we have a midline approach with the consideration of the venous system, superior sagittal sinus, and of course the veins. And then we decide how we place the patient, how we position the patient, and how we position the Mayfield clamp. We also always try to make it very on the right angle shape, and this is how we did it also in this case. So here, schematically, we draw the precentral gyrus, the lesion, and how we would do the skin incision, a straight incision, and then 2 burr holes on the superior sagittal sinus, and this craniotomy in a parasagittal way. The patient is positioned here with a little bit tilted head and just straight. The neuronavigation system is, of course, set and built up for the exact localization of the tumor. And then we start the surgery, and in the following minutes, you will see a summary of the surgery. And I will comment it. So after we position the head and set the neuronavigation, the hair is shaved, and we mark the skin incision and the craniotomy, how we would do it and plan to do it. After the disinfection, we drape with some belly wraps and put iodine foil on just to keep it clean during the surgery. And here we have a simple superficial tumor case, so no specific approach with acquisition of periosteum or etc. has to be planned. So we just make the straight incision until the bone, and the retractor is placed here, and you cut the periosteum and pushed it away. And then we usually use the neuronavigation pointer just to mark the craniotomy. I think it's very nice, just always let the resident do the craniotomy, and they learn it really good if they have just to mark it again and just to be clear and aware of where they have to place the burr holes and how to do the craniotomy. And classically, of course, you do the 2 burr holes on the superior sagittal sinus. And of course, it's a matter of taste whether you do via trepanation or use the drill. So I usually use the drill, and then do the craniotomy, of course, away from the superior sagittal sinus from both sides, and then at the end on the midline. Remove the bone flap, just to be careful with the dura if it is thick, so you have to carefully prepare and dissect it, and then just irrigate so you have a clear situs. Open the dura in this situation always in a rounded shape directed to the sinus and not another way. And this is also the dura incision, which can be sutured very well. A tucking suture just to pull away. And as we have a tumor which is in the pre-central gyres as well, we do the MEP monitoring via cortical strip. So we have a safety here. The tumor was located here right beneath a very thin layer of brain tissue. So you can use the navigation pointer to make see where the optimal entry point is located, and then just use the bipolar to make an entry, a corticotomy. So either you use the bipolar and the sucker, or inside the knife for the arachnoid membranes or PIA. So after the incision of the cortex, you can use the sucker and the bipolar, and here is also the very hard lesion, which resembles as a radionecrosis as a result of the previous radiation therapy. So in this case, we tried to remove it en bloc, and we started at the part from posterior, going from posterior to lateral, and just sucking and a little bit of coagulation, and then you can easily dissect between the normal brain tissue and the lesion. And you see here also from the color that there are different types of tissue in this tumor. There's gray and yellowish tissue, showing that there are different qualities of this tumor. So at the end, the preparation was performed in the frontal part and in the lateral part, so that the whole tumor was dissected from the surrounding tissue with bipolar and the sucker, and then removed en bloc. Afterwards, I usually place this Surgicel and or Tabotamp and irrigate for at least 3 to 5 minutes. It's the best way to have a good hemostasis, and you should be sure with the hemostasis as always, or as previously already said. So the dura closure was performed by a continuous suture. And if you're not sure whether it's a watertight or a dura closure, of course, you can put some Tacozil, which is a matter of cost, of course, on just to make sure that you have a watertight closure. I have a good experience with that, so I usually use it. Not in all cases, but try to make sure that the dura is closed watertight. The bone flap is replaced or reimplanted with titanium mini plates, and the skin suture as in a usual fashion. So this is how we do it here. And there are some points regarding the techniques which I would like to mention. So here we performed an en bloc resection, and this is something you should always go for it if you have the chance to do the en bloc resection. Of course, in large tumors located in eloquent regions, you have to do the piecemeal resection, but in all cases, if it is possible to do an en bloc resection, you should go for it. And apart from that, there are several studies who showed that there is an infiltration zone, not only in glioma, but also in metastasis. And some metastasis types have about a 5 to 10 millimeter surrounding tissue, which is infiltrated by tumor cells. So if you have the possibility from the location of the tumor to do a supramarginal resection, then it is highly recommended. This series, which is already from 2010, but it shows very nice that the risk for a tumor recurrence is very high if you have a piecemeal resection and also a large tumor. Of course, these both things go side by side, but in all cases, you have the possibility to do an en bloc resection, then you should go for it. So the take-home messages from my side in case of a tumor resection, metastasis resection is, of course, the goal. The indication should be always to delay and prevent neurological deterioration and prolong survival. The resection of symptomatic metastasis should be indicated by us and, of course, the oncologist, independent from the number of the lesions in the brain. And the resection of eloquent metastasis, one should not be afraid of that, as the highest likelihood, they bear the highest likelihood of clinical improvement. And supramarginal en bloc resection is associated with a better PFS and OS. Thank you very much.
Thank you, Narine, for your talk. We have 2 questions in the Q&A that are concerning your talk. I'd like to rephrase one of them. How do you identify a brain met on the MRI?
Of course, usually it's a contrast-enhancing tumor, and the most, I think, what it differentiates from the glioma is, of course, you have to know the history of the patient, whether somebody has already a cancer type. And if we don't know something about the history, often the brain metastasis have much more edema than primary intrinsic tumors. But of course, until you have removed, you cannot be sure whether it's a metastasis or it's a primary brain tumor.
The second question is concerning your way of corticotomy. Would you have considered also a transsulcal approach for this particular tumor?
Yes, of course. Yeah, I also thought about it, but as it was a very, very thin layer of brain tissue on the tumor, you can go for a corticotomy.
So I don't see any more questions right now, because the last one I will touch briefly upon and we can discuss after my talk.
Mm-hmm.
So now I have to share my screen. So the last talk for today is how I do a supratentorial non-eloquent glioblastoma. I have no disclosures concerning that. So the basic principle of glioblastoma surgery is that you have a certain tumor. Somewhere in this case, you have 2 tumors, but you also have a lot of infiltration around it. And this infiltration is actually giving us problems because we have to know how far to go and where to stop our resection. So historically, in the dark centuries, like up until 2006, the planning was with contrast MRI, And if it's enhanced, it needed to be resected. Then came 5-ALA for glioblastomas. So now we can say if it's fluorescent, it needs to be resected, and you end up in doing larger resections than before. And maybe in the very near future, we will say if it's no more fluorescent, it needs to be resected too, because we are aiming for large supramaximal resections, sometimes also called flarectomies. So this is the study you know from the Stummer group showing a survival benefit for those with more resection, but you can also like improve the resection with an MRI or with an ultrasound. So whatever you have to improve your extent of resection will be worth it for your patients. What do we need for neurooncological surgery? And this has been touched by Paivi before. So you basically need a pair of micro scissors, a bipolar, and a suction unit. That's what you definitely need. But it's also nice to have a microscope. It's also nice to have a Mayfield or other devices to hold the head. And it's also very nice, and I consider it a standard, all the three of those, to have a neuronavigation, but it's not absolutely mandatory. And it's also nice to have an ultrasonic aspirator in larger gliomas, and also by the use of 5-ALA, you will have a nicer way of resecting tumor if you just take the ultrasonic aspirator. Preparation of surgery, this is how we do it in Innsbruck. So it's not everybody has to prepare a presentation, but whenever a resident from our department is doing a tumor case, they have to prepare a PowerPoint, as you see this, like photographed yesterday morning, where they discuss positioning, where they discuss the approach, the craniotomy, and what they expect, and how they want to start the surgery, where they want to start the dissection. In this particular case, the patient also had a skin lesion, so that's why we have a picture with the incision, because plastic surgery came in to excise the skin lesion, so that's not the normal preparation. But this is what we do every day when a resident is allowed or is doing a brain tumor case. We see this preparation, we see this presentation, and we discuss the cases with them. So straight into today's case, we have a 64-year-old female who harbored neuropsychological symptoms for a couple of weeks, 3 to 4 weeks. The relatives mentioned a cognitive decline. She kind of was confused, and that's why they went to their family physician, who sent her to a regional hospital, who did a CT scan, showed a large edema, and they sent her to us for further workup. She had no previous medical history whatsoever, absolutely healthy. And these are the scans where we see the contrast-enhancing central necrotic mass in the right temporal lobe. You also see an extensive swelling on the T2 images here, so a large edema. And since she had no swelling whatsoever, and the typical presentation of this like border contrast enhancement with central necrotic features, we thought it might be a glioblastoma. So what do you have to ask yourself if you see a patient like this? What might this be? In this case, rather easy high-grade glioma. Can you get a diagnosis through biopsy resection? We aimed for resection in this case. What is your goal and extent of resection? In this case, we aimed for a gross total resection, since it's not eloquent. What approach do you choose to get there? This is a rather basic temporal craniotomy. And what technical adjuncts do you want to have? For this case, we used navigation, 5-ALA, and ultrasonic aspirator, as we can easily approach those things. So we're going to dive right into the video. Let's see if that works. You probably should see a moving video right now. So first of all, what I did is check with the pointer if the navigation is still accurate. So I just put it on the dura to see if there is any navigational shift. Then we go straight into the corticotomy. If there is vessels and sulci involved, you might want to spend more time doing the corticotomy. And after the corticotomy, I switched immediately to the 5-ALA blue light, which can emphasize this reddish tissue here. Whenever there's some bleeding, the red goes away. First of all, we harbor some tissue for science. So this goes into cell culture, where we know it's still red fluorescent tumor, so it's going to be vital. And then you work your way around the fluorescent tissue. And the problem in the beginning is it's all dark since there is some blood involved. And I usually don't like to coagulate that much around the tumor border. You will have to work with the suction and the ultrasonic aspirator to always see where you're resecting tumor. And if you get rid of the red tissue, you can see that the brain looks rather gray below there. I used to place a cottonoid for hemostasis because, as I mentioned before, I don't want to coagulate. This is the borderline between the regular tumor and the regular brain. So you work your way circumferentially around the tumor using the white light, and you remove some bits and pieces of the tumor all the time, since you will have a hard time with a small craniotomy to see beyond that. So you're dragging the tumor away. Now you can see the temporal dura, so that you know that you also reach the base of the tumor. That's always bleeding. The cortical, oh, that was not intended. The cortical veins are always bleeding. Start it again here. And then you continue removing the tumor piece by piece. If you're lucky, you can grab larger pieces. With the cottonoid, you can retract the rest, and you see the temporal dura more exposed, so you can see that the base is already done. And then you continue work with the 5-ALA and the ultrasonic aspirator. You can see the remnants of the reddish fluorescence. Sometimes it's nice to wipe with a cottonoid over the tissue so you can get rid of the blood, or also some CSF will give you a hard time looking beyond. You can see the ventricle here opened a little bit. That's the ependyma. Then you use the ultrasonic aspirator to just get rid of all the red tissue, which is actually, it's like coloring after numbers. It's really easy. And you can see that there is no fluorescence left. And after the tumor is removed, it usually immediately stops to bleed. Usually it's immediately a dry site. I also like to use Surgicel because it gives me a nice night of sleep after surgery. I'm not sure still if it's really worth doing it, but we are used to do it. And that's why we still stick to it. Gives you a nice feeling as a surgeon. What we do post-operatively is we put our patients to the neurosurgical ICU for one night. This is the local standard, mostly not challenged. Couple of years ago, even more patients went to the ICU than today. We keep the systolic blood pressure below 140. We do the MRI usually the next day, but at least within 48 hours, but 72 is also perfectly. But that's what we do. We usually do it next day, or if the patient is not feeling well after at least 48 hours. Dexamethasone is ongoing, but we try to taper it very early, so next day or the day after. We don't use anti-epileptic prophylaxis routinely. If there's a new neurological deficit that is unintended or unexpected, then we do a CT or an MRI, depending on the patient's state. If there is new symptoms like new seizure, we also do a CT. And if there is prolonged weaning, we also do a CT just to get assured that there is no major rebleed. This is the post-op imaging showing that the contrast enhancing was resected, and it's also larger than the contrast enhancing mass before, since it's due to 5-ALA, the resection is usually larger than you expected. And with that, I thank you for your attention. And I keep on moderating. So we have two questions in the, three questions now in the Q&A. Do I go for extensive resection for butterfly gliomas? Honestly, usually not. I know that there is data on butterfly gliomas. I know that people argue that a large resection is worth doing. I personally never encountered a large butterfly glioblastoma in a patient where I thought it's worth doing the very risky resection. So in that case, I've never done that. Do I routinely use cortisone or mannitol opening the dura? In gliomas, actually, I rarely use mannitol. Some of them are on dexamethasone anyway, but I don't use an extra dose for that. And mannitol very rarely. And one question that is rather long from before, and this is one thing we can discuss if we want. Left frontal region low-grade glioma operated in the absence of neuromonitoring and neuronavigation. What would be the goal? Maximum safe resection or functional preservation with tissue diagnosis? So I would say, first of all, you don't need a navigation or a monitoring for left frontal glioma. You could also do this awake, but you will need a neuropsychologist. This will be also a problem. So I would personally aim for maximal safe resection, but I put a very hard underline on the safe and not on the maximal. What do you think? Päivi? I have to point the finger at somebody. Everybody is nodding.
Very similar, maximum safe resection. And I think either you do a neuronavigation guided resection, or if it's in the frontal operculum, you should always go for awake surgery.
Laura, what would you do in this case?
Can you?
Yes, we can hear you. Now we can hear you.
Hi. So my idea that we cannot overstate the safe part. Are bound to somehow best quality of life. So quality of life is mandatory. I think is the most important part here. I think besides a well-done activated surgery, but we have to take it to be very aware of quality of life for those patients.
There was the add-on information coming in that awake is not possible. So I would strongly advise you to just do whatever's safe for the patient and try to get a histological diagnosis. Because if you don't have the means for awake craniotomy, then you will have a hard time on a left frontal low-grade glioma, if it's a truly low-grade glioma. So I can't advise you to risk a lot. As Laura mentioned it, quality of life is the most crucial thing in those patients. So some more questions in the Q&A. Survival rate for such patients with a high-grade glioma strongly also depends on what you do afterwards. We don't how the MGMT methylation status is. So according to the data, it's somewhat between 15 to 21 months, depending on the means of treatment. It's very hard to say, since I actually don't know that the case is like 2 weeks ago, so I can't tell you actually the MGMT yet. But it will be better if you resect the 5-ALA completely, definitely. And I always start with the ultrasonic aspirator as far as I use 5-ALA, because I think it's easier to get rid of the red tissue with the ultrasonic aspirator, but it's not necessarily you use the ultrasonic aspirator. So my dear panelists, I wanted to ask you some things. First of all, and we are focusing on also a lot on training and on how to teach like the next generation residents and fellows. And Päivi, surgical preparation, you mentioned, is one of the most important things in tumor surgery, and I couldn't agree more. But how do you train that? How do you tell your residents how to prepare perfectly?
I think it's really important, if possible, just that as a resident, you go with the senior, see all the steps, like you are just not visiting the OR and say, can I please join? But you ask, is it possible just me to check what you do beforehand? That's really important. And I would highly recommend to use new stuff. Like I find ultrasound in navigation really good. You can, but it's, as I told in previous talks, I said that it's really difficult to learn how to use it, and it's a bit difficult to use as a tool for evaluating the extent of resection. But I'm really happy that if a resident comes and says that, can we please check, can you please call me when you do the navigation plan or something, and can you please tell me why do you use this, why do you use lateral position and something like that. So stay alert and learn from your own seniors.
Matthias, you're head of a department. How do you train your residents in those cases?
Would you mind if I just have two comments to the cases that we just discussed? In terms of butterfly glioblastoma, in tumors crossing the midline, in multifocal disease, and in tumors involving the corpus callosum, my concept would be to go with the clinical status of the patients. If there's a glioblastoma and the patient, is neuropsychologically intact, you can probably go for resection. If not, you should probably not do it. That would be my policy in such cases. Again, I'm with you. I have not seen cases with a large, true butterfly glioblastoma who have benefited from large operations. And then for the left frontal low-grade glioma case, I think a lot depends on how the MRI precisely looks like. You think you have a safety distance to the pyramidal tract? Do you think you have a safety distance to the speech networks? If you think you have, you may aim for a GTR. And a lot, at the other point, will depend on your ability to distinguish between tumor infiltration and healthy brain during the surgery. So maybe you get lucky and you have a dissection plane and you can take it out. If you don't have that dissection plane, of course, just stop. So just two comments. And now you asked how do we train?
How do you train your residents and your young fellows?
We're not doing it in as much a formal way as you do, so they don't have to prepare a presentation the day before. But yes, we have an afternoon or a conference where we discuss the cases and where we, go briefly through the cases, talk about positioning, the craniotomy that we're going to use, and of course all the adjuncts that we're going to use and what the surgical goal will be. In terms of how do you train a junior person to become a mid-term person, become a senior person, I think everything starts with positioning, learning how to use neuronavigation, how to do an incision, and shaving, all these things. So this is step one. Step two would be a craniotomy. Yes, as you already mentioned, we like to have the junior person do the craniotomy and see this as a module in the whole procedure. So you have the module positioning, etc. You have the module craniotomy, the interdural part, dural closure, and closure beyond dural closure. And then we try to take the junior people through these steps. And in terms of what pathologies to do, of course, small, non-eloquent, convexity meningioma, small metastasis, these are the first ones. And we, eloquent cases, we don't have residents do them, at least not alone. That would sort of sum up our policy.
You mentioned the metastasis as a resident training case, and this was also how the way I was brought up. The metastasis was the case where you learn the intraparenchymal part of the surgery. And since Noreen mentioned nicely that there is also infiltration around, and there's people arguing that you should take out not the dissection plane as a surgical plane, but the tissue beyond the dissection plane as an infiltrative zone. Noreen, what would you say? Is this still a resident surgery?
Yes, I would say it's not the first, second year, of course, but a resident in the 5th and 6th year should be able to do that. And it's the perfect tumor to learn how to remove also then later on gliomas. So I think the technique with the suction and bipolarization and just to be able to also go for the peritumoral tissue is the perfect way to learn the removing technique also for intrinsic tumors.
Giovanni, you raised your hand.
Yes, I raised my hand for a comment to the previous case, but before giving to you my comment on the case of the left frontal low-grade glioma, I want to continue with how to train residents. I think my suggestion to young neurosurgeon, young residents is to stay together with your senior from the beginning, from when you see the MRI scan for the first time, and then stay with him, ask you a question for each single step before entering the OR, and also during the positioning, during surgery. So for residency, it's crucial to understand why the senior is doing something. That could be positioning or the superior resection and so on. So they must be very close since the beginning with their senior. That will be the best way, in my opinion, to learn how to do this kind of surgery. And if I may, I will also make a comment about the left frontal low-grade gliomas. The question said that it was involving the superior and middle left frontal gyrus. And probably a wake surgery could be used, but if wake surgery is not possible, today we can use also some preoperative functional imaging that can allow us to identify before surgery eloquent structures. So if we cannot perform a wake surgery because we don't have the neuropsychologist, or we don't have the expertise in our anesthesiology team, for example, we can use functional MRI, tractography, TMS to localize eloquent structures. And if we are far away from this structure, we can continue doing our surgery without anything else. In the specific case, I think the higher risk is the development of SMA syndrome, so supplementary motor area syndrome, probably, not for language. I'm not sure, I'm not seeing the case, but if today we have some tools that we can use before entering in the OR that can be really helpful to avoid postoperative deficits. Even if I
totally agree, but I'm afraid in the place where you don't have mapping, monitoring, or neuronavigation, you will have a hard time finding an NTMS or a functional MRI. But generally, you're totally right. There's different ways to do that.
But you know, probably functional MRI, it's easier to find functional MRI because it's just a software that is implemented in the MRI scan. So that could be helpful.
Is Laura still on? Because I actually wanted to ask her something right now. Well, maybe, yeah, dark where you are. So we heard you should stay with the senior as a young resident. And I totally agree. But as also the young residents have work to do in the hospital. So how did you stay with your seniors to balance between doing your work and not standing on their nerves?
On their nerves. You have to stand on their nerves. There is no way. There is no other way, I think. You have to be present. And sometimes you have to be present at times where you would love to go home and sleep. But sometimes those are the best moments for teaching, the calmer moments for I don't know, for reviewing images together and to maybe practice shooters. There are the tiny things that can help very junior residents to be to become better and more proficient and quicker in becoming ready for the OR for procedures. So I'd say that you have to be there the most that you can. And I did stand on the nerves of my seniors, but my juniors do the same. They're here right now, so yeah.
Because you told them to do it, because they know how to do it.
Oh, you can look at them, right? You can wave.
Yeah.
So I know, because they want to listen to you all, and it's a very nice webinar, and I'm very happy to participate. And thank you for organizing it, Christian. It was very helpful for
It's a
them.
pleasure to have you all here. Matthias, you raised your hand as well.
Yes, if you forgive me, one comment on metastasis surgery. Of course, not all brain mets are the same, and a lot of them are very difficult to do. For example, Noreen's case with a pre-radiated case can be very difficult to find the dissection plane, know where you are, and maybe you end up taking out more tissue than you want. And of course, this has to be anticipated. Not every metastasis is an easy residence case. Also, at least in our hands, and we looked through quite a few metastasis patients, whenever they incurred a new neurological deficit, the prognosis was just dismal. So indeed, you have to pay careful attention that these patients are not hurt during the surgery.
So for future training, like if we can twist the clock 30 years back, residents 30 years ago, they had intracerebral hemorrhages they could practice on. And there came out a couple of trials, and they're basically gone. They had brain mets they could practice on. Now we're challenging more and more brain mets with radiosurgery, but also we have more and more challenging brain mets to do surgery. And we also, as our understanding of quality, we want to do the brain mets as good as everything else. So in the future, how do we get our residents trained for those cases? With lower and lower numbers, and also lower and lower time spent in the hospitals. Everybody's welcome.
I can't confirm lower numbers. I think there's still, again, I mean, there are enough small incidental and other findings that do require surgery, so I can't confirm lower numbers. Working hours is a severe concern, and I don't have an answer to that.
What I meant with lower numbers is we have more and more residents to cover the working hours.
Yeah.
So the cake is not bigger, but we have now more people who want to enjoy the cake. Additionally, we have more and more metastases we challenge that are challenging surgeries. As you mentioned, Noreen's case is also not like a walk in the park case. So also cases that are taken away from resident education. So that's why I meant lower numbers. Maybe I have to precise lower numbers per resident. How do you in Mainz challenge that?
I think up to on the long way or in the future, probably we have to prolong the education time. So I think it has to be done just to make sure that the residents gets enough experience and get the numbers and can do the surgery at the end of their education. As the working time and the number of residents is increasing, working time is lower than at our time as when we had our training. So I don't see a better solution for that. So we have to divide these patients on the number of residents, and we have to train them. And of course, every hospital has its own training schedule, but probably we have to do more courses on cadavers or probably stuff like this just to make sure or integrate some kind of training sets apart from patients in the education as well as necessary or mandatory or probably prolong the education time.
Baby, how do you challenge that in Helsinki?
Yeah, I'm a actually in charge of the planning the surgeons for everyone. So I make the surgery list. So we actually try to give residents operations, but it's really hard because they are fighting over those, but that's what we do. We try to give them more than well, I was one of the lucky ones. I started my training over 20 years ago, so I'm one of those who got to operate a lot as a resident. So, but we are trying to manage things with that planning, surgical planning, who gets to operate and what. And of course, it's always in the beginning of residency, the more you are on call, the more you learn. Then you have your senior is a private teacher. So that's what they know, and that's why they want to do a lot of phone calls.
Actually, I wanted to ask Laura as well, because I saw your face when Naureen proposed the longer residency time. I saw your facial expression, and I want to hear what you thought.
I think this is a very this is a temptation, like prolonging time. In my opinion, though, you don't have to prolong time as it is now, like 8-year resident. You just have to be aware as a European association that we need fellowships on a European scale. And we need, not everyone wants to do neurooncology. So for those who really want, there has to be an early start of training so that they can get on a oncological fellowship early on. And that's how we train them. There must be somehow a selection of those among us who wants to really dedicate on oncology or on anything else. So, and then we have to manage to build fellowships. I think this is what needs to be done. Also, we can, in my opinion, use I'd say on a constant note, we can use simulation, which is becoming better and better with the time. So we have tools, and we can implement some. Of course, we are all aware that the number of surgeries can be because of better therapies, because of adjunct therapy, because of gamma knives. There are many different solutions to this, but the lower number of surgery can be rearranged for those who really want to dedicate themselves to oncology. This is what I think. We need to.
Giovanni, how do you tackle lower numbers and lower working hours?
So I agree with Laura that for post-residency, fellowship can be a solution to improve their surgical skills. But if we are dealing with the lowering of number during the residency program, I could say that in Italy, we have this kind of issue. It is a main issue because we had in the last years an increased number of residents also in neurosurgery. And we tried, the Italian university system tried to solve this issue by sending residents also in non-university hospitals. So they are doing rotation in non-university hospitals, working in neurosurgical departments that are not university departments, but in which good neurosurgeons work. And the residents are really happy about that because usually they are the only 1 or 2 residents in that neurosurgical department, so they can work a lot. And probably usually they work more when they are in the non-university hospital instead of when they are in the university hospital, because in the university hospital there are the other residents. So there are some periods in which they are rotating and can be exposed to a higher number of surgeries.
Very good. So I think we're one hour in. I think the discussion was very good. I would like to thank all our speakers and our panelists for very fruitful discussion. I'd like to thank more than 100 participants for spending time with us in this webinar, and I wish you all a very pleasant evening. Thank you for joining. Thank you for talking. Thank you for discussing, and looking forward to see you all soon.
Thank you very much. Bye-bye.
Thank you all.
Thank
Bye-bye.
you.
Thank you. Bye-bye.
Bye.